Hello. Today's lecture will address the behavioral objectives for week 2 in the syllabus. Because the file is so large, this will be presented in two parts, Part A and Part B. Make sure to watch both parts to avoid missing critical information. Today we will begin with pain. And in the past, there have been many fallacies regarding how infants and small children experience pain. We will address those now. 1, this is not true. Basically, it is that infants do not feel pain. The fact is, infants demonstrate behavioral, especially facial and physiologic signs and symptoms, including hormonal indicators of pain. Neonates have the neural mechanisms to transmit noxious stimuli by 20 weeks of gestation. Something else that's not true. Children tolerate pain better than adults. The fact of the matter is that children's tolerance for pain actually increases with age. Younger children tend to rate procedure-related pain higher than older children. Something else that is not true, children cannot tell you where the pain hurts. Actually, by 4 years of age, children can accurately point to the body area or mark the painful site on a drawing. Children as young as 3 years old can use pain scales such as faces. Something that's not true, children always tell the truth about pain. The fact of the matter is children may not admit to having pain to avoid an injection. Because of constant pain, they may not realize how much they are feeling and not ask for analgesia. Something that is not true, children become accustomed to pain or painful procedures. The fact is, children often demonstrate increased behavioral signs of discomfort with repeated painful procedures. Something that is not true, behavioral manifestations reflect pain intensity. What is true is that children's developmental level, coping abilities, and temperament, such as activity level and intensity of reaction to pain, influence pain behavior. Children with more active resisting behaviors may rate pain lower than children with passive accepting behaviors. Something else that is not true. Narcotics are more dangerous for children than they are for adults, and addiction to opioids used to treat pain is extremely rare in children. So we must remember, if the child is in a lot of pain, don't hesitate to use opiates. They are not more dangerous for children than adults. As a matter of fact, by 3 to 6 months of age, healthy infants can metabolize opiates similarly to other children. When we're assessing for pain, what kinds of questions can we ask for the verbal child? Tell me what the pain is. Tell me about the hurt that you've had before. What do you do when you hurt? Do you tell others when you hurt? What do you want others to do for you when you hurt? What don't you want others to do for you when you hurt? What helps the most to take away your hurt? Is there anything special that you want me to know about you when you hurt? Pain assessment and management in children. There are actually 6 core domains which are recommended for measuring pain in children. The pain intensity. There are 3 types of measures that are used to measure the domain of pain intensity. The first one is the behavioral measures. These are useful for measuring pain in infants and pre-verbal children who do not have the language skills to communicate that they are in pain, or when mental clouding and confusion limit a child's ability to communicate. Behavioral pain assessment may provide a more complete picture of the total pain experience when administered in conjunction with a subjective self-report measure. Secondly, physiologic measures. Note that these are not able to distinguish between physical responses to pain and other forms of stress to the body, but they do provide useful information about general distress levels of children experiencing pain as well as stress. Physiologic parameters would include heart rate, respiratory rate, blood pressure, pulmonary sweating, cortisone levels, transcutaneous oxygen, vagal tone, endorphin concentration, which reflect a generalized and complex response to stress. Remember, these are not something that can tell you where the pain is, but this can let you know about generalized distress. And lastly, self-reporting. Additionally, we want to assess satisfaction with treatment, symptoms of adverse events, physical recovery, emotional response, and economic factors to pain management. So let's look at a couple of pain scales that we see in infants and children. The first one is typically used between 32 weeks of gestation until the child is 6 months of age. And it is called the CRIES scale. That is an acronym. We are assessing crying, oxygen requirements, increased vital signs, facial expression, and sleep. The observer will provide a score of 0 to 2 for each of the parameters based on changes from baseline. The first one is crying. The characteristic of the pain is typically high-pitched. So if there is no cry or the cry is not high-pitched, that's a 0. If the cry is high-pitched but the baby is easily consoled, they get a 1. If the cry is high-pitched and the baby is inconsolable, now they get a 2. Oxygen. So if they require oxygen, that would be due to you need to maintain an oxygen saturation over 95%. Here you want to look for changes in the oxygenation. Babies experiencing pain may have a decrease in oxygenation, so we will measure that usually using the SaO2, but it can also be measured with a TCO2. If no oxygen is required, they get a 0. If less than 30% FiO2 of oxygen is required, then they get a score of 1. If more, then they get a score of 2. Please remember, you need to consider other causes of changes in oxygenation like atelectasis, pneumothorax, oversedation, or maybe they even need to be suctioned. Next, we're going to take a look at increased vital signs. Note, please take the blood pressure last because this may wake the child, causing difficulty with the other assessments. You want to use the baseline pre-op parameters from a non-stressed period. You're going to need to first multiply the baseline heart rate by 0.2 and then add this to the baseline heart rate to determine the heart rate, which is 20% or over baseline. Do the same thing for the blood pressure. You want to use the mean blood pressure. So when you're evaluating this parameter, if the heart rate and blood pressure are both unchanged or they are less than the baseline, they get a 0. If the heart rate or blood pressure is increased but less than the 20% that you calculated, they get a baseline score of 1. But if either one, the heart rate or the blood pressure, is over 20% baseline, then they get a score of 2. Expression. Here, the facial expression is often associated with pain is a grimace. This may be characterized by brow lowering, eyes squeezed shut, a deepening of the nasolabial furrow, open lips and mouth. If there's no grimace, then they get a 0. If there's a grimace alone, they get a score of 1. If they have a grimace and possibly grunting, which is more for vocalization, not due to an issue with breathing, then they get the score of 2. Sleepless. This parameter is scored based upon the infant's state during the hour before this recorded score. If the child's been continuously sleeping, then they get a 0. If they awakened at frequent intervals, they get a score of 1. If they were constantly awake, then they get a score of 2. You will add everything up and you will then get a score. If the infant has a score of 4 or greater, please make sure you medicate that poor baby. The flat scale. This is useful for people that are 2 months of age to 7 years of age. This looks at the child's face, legs, activity, crying, and consolability. The scoring range, 0 is no pain, 10 would be the worst pain that they have. So the face here, if they have no particular expression or smile, it's a 0. Occasional grimace or frown, withdrawn and disinterested, they would get a 1. Frequent to constant frown, clenched jaw, or quivering chin, they get a 2. Legs, normal position or relaxed, earns a 0. Uneasy or restless or tense, they get a 1, I beg your pardon. And if they are kicking or their legs are drawn up, then they get a 2. Activity, lying quietly, normal position, moves easily, they get a 0. Squirming, shifting back and forth, intense, they get a 1. Arched, rigid, or jerking, they get a 2. The cry, if they are not crying, either awake or asleep, that's a 0. If they are moaning or whimpering with an occasional complaint, they get a 1. If they are crying steadily, screaming, or sobbing with frequent complaints, that gets you a 2. Consolability, content and relaxed is a 0. 1 is they are reassured by occasional touching, hugging, or talking. Talking to. And if they are difficult to console or comfort, then they get a 2. Next, we're going to talk about the FACES pain rating scale. This is for children as young as 3. This consists of 6 cartoon faces ranging from smiling for pain, that is a 0, to a tearful face for the absolute worst pain, which is a 10. The child is asked to choose the face that best describes their own pain, and then the nurse can record the corresponding number. Remember, the FACES scale is typically an even number, 0, 2, 4, 6, 8, 10. Children about 8 years of age, when they have a good grasp of numbers, can use the number scale. So pain response by age. Young infants' response to pain. In general, you're going to see that rigidity, thrashing, loud crying, grimacing, facial expressions of pain, and they don't understand the relationship between a stimuli that is causing pain. Older infants' response to pain here, they'll withdraw from painful stimuli. They'll cry loudly, they'll have facial grimacing, and they will do physical resistance. They'll try to stop it. A young child here, their response to pain is loud crying and screaming, verbalizations like ow or ouch, it hurts. They may thrash their limbs, and they may push the stimulus away. School age, here their response to pain is they may have stalling behaviors. They might say, wait a minute, hold on a second. Muscle rigidity, they may use all of the behaviors of a young child as well. Adolescent response to pain, usually they have less vocal protest, less motor activity. They still have an increased muscle tension and body control. They will also verbally let you know, this hurts, you're hurting me. A little bit about your nursing care guidelines and non-pharmacologic strategies for pain management. So 1, you can use a child life specialist to help explain and allow the child to express how they're feeling about their pain. You can use non-pharmacologic interventions to supplement, but not replace pharmacologic interventions. And you also want to use non-pharmacological methods for mild pain and pain that is reasonably well controlled with analgesics. You can also add non-pharmacologic strategies as well. Here you want to form a trusting relationship with the child and family. Let them know that you are concerned about their pain and intervene appropriately. Take an active role in seeking effective pain strategies that help them no longer feel the pain. When you're preparing a child for a procedure, especially if you know that it may be uncomfortable, you want to explain to the child what they may feel, but you don't want to put the idea in their head that, oh, this is going to be very painful. You can let them know what the sensation will feel like, a pushing, a stick, a pinching. Sometimes it doesn't bother people. You want to use non-pain descriptors. You don't want to say something like, has a burning sensation. You may want to say that it may feel a little bit hot. Also avoid saying things like, oh, this is a terrible thing. This is really going to hurt. Again, we don't want to plant those kinds of thoughts in the child's head. Do stay with the child during a painful procedure. Allow parents to stay with the child if the child and parent desire. Encourage the parent to talk softly to the child and to remain near the child's head. Involve the parents in learning specific non-pharmacologic strategies and in assisting the child with their use. Educate the child about the pain, especially when explanation may lessen anxiety. Reassure the child that he or she is not responsible for the pain. Teach procedures to the child and the family for later use. Some specific strategies include distraction, relaxation, guided imagery, positive self-talk, behavioral contracting. Please remember, whatever is painful to an adult is painful to an infant or a child. Infants respond with their whole body to pain, while older children can localize the pain. Preferred methods of pain management include the oral route and the IV route. Ideally, we try to avoid utilizing IM injections. Children don't like shots. The dose for pain medication is usually based on the weight in kilograms. If a child is on narcotic analgesics and they are not effective, consider increasing the dosage versus changing the medication. Continuous infusion analgesics, these help to keep the pain at a constant level, especially if somebody is in constant pain. Hopefully this can keep it at a level that is manageable for the child. A PCA is good for the first 48 hours after surgery for children 5 years old and over. Remember, PCA, the patient needs to be able to press the button. Usually we use morphine in a PCA. Keep a handle on the pain. If it is not treated, you end up needing more medication to get control of the pain. Keep Narcan on hand and calculate the dose based on the weight in kilograms or the body surface area. Monitor for sleepiness, small pupils, shallow or decreased respirations for possible development of respiratory depression. Children that are at increased risk for respiratory depression are children that have altered levels of consciousness, unstable circulatory status, a history of apnea, or known airway problems. Please note that Demerol can cause CNS excitability, agitation, tremors, and seizures. We prefer not to use it in the pediatric population. We do want to monitor for tolerance. Here, you may need to use increasing dosages of a medication over time to achieve the desired result. If the child is on a medication for a few days with increasing breakthrough pain, the child may need an increase in the medication, or they may need to change the medication and use a stronger medication so that you can have the same effect. And we want the effect to be as effective as possible. Please note that a baby that is having ear pain may roll their head side to side. This can help us to know that that may be the problem. Also, when a baby is having ear pain, they may be pulling at their ear. So we already talked about some non-pharmacological strategies to reduce pain perception. Note that this does not make the pain itself go away. It just makes it so that you're not paying so much attention to it. Parental involvement significantly decreases the child's or infant's anxiety, and this is considered one of the most powerful non-drug methods of pain relief for children. We've already talked a little bit about distraction. Note that this takes the attention away from the pain. Do not assume the pain is gone if a child can be distracted. You can use ELAC cream for IVs or lumbar punctures. You'll apply a thick layer of the cream, and then you will cover it with either an opsite or Tegaderm, and then you need to wait at least 60 minutes for it to be effective. ELAC cream. This can be used for open wounds as a numbing agent, and this is effective for about 15 minutes. For immunizations, here you can tell the child to look away, take a big deep breath, and then blow hard and fast to help blow away the shot pain, kind of like blowing bubbles. The benefit of good pain management is it really helps a child to maximize their functioning. They'll eat better, they can get up and walk around, and they can really participate more in the recovery process. Next, we're going to talk about concepts of death and dying. By the ages of 9 to 10 years of age, kids begin to see death as real, irreversible, universal, and something that will happen to them. They may see it as destructive and violent. They may have exaggerated concerns about death. They may fear death and have death anxiety due to a perception of loneliness associated with leaving what they know or leaving their family. You want to encourage the child to talk to their parents about how they're feeling, and this will help to prevent them from feeling alienated. There is a table in your textbook that addresses all of the different stages of how they look at death, their reactions to death, and their interventions, but we are going to cover that now. So the infants and toddlers, their concept of death really has the least significance to children under 6 months of age. After the parent and child attachment, the development of trust is established, the loss, even if it's temporary, can actually be very profound when they lose that significant person. Prolonged separation during the first several years is thought to be more significant in terms of future physical, social, and emotional growth than at any subsequent age. Toddlers are egocentric and can only think about events in terms of their own frame of reference, which is living. Remember, they are egocentric. Their egocentricity and vague separation of fact and fantasy make it impossible for them to understand the absence of life. Instead of understanding that death, this age group is affected more by the lifestyle changes or the disruption in their routine. Their reaction to death, with the death of someone else, they may continue to act as though the person is alive. As children grow older, they will be increasingly able and willing to let go of the dead person. Ritualism is important. A change in lifestyle could be anxiety-producing. This age group reacts more to the pain and discomfort of a serious illness than to the probable fatal prognosis. This age group also reacts to parental anxieties and sadness. What can we do as a nurse? Help the parents deal with their feelings, allowing them more emotional reserve to meet the needs of their children. Encourage parents to remain as near to the child as possible, yet be sensitive to the parents' needs. Maintain as normal of an environment as possible to retain the routine and the ritualism. If a parent has died, encourage having a consistent caregiver for the child, and promote primary nursing. Preschool children, here their concept of death is that they believe their thoughts are sufficient to cause death. The consequences is the burden of guilt, shame, and punishment. Their egocentricity implies a tremendous sense of self-power and omnipotence. They usually have some connotation of its meaning. They usually see it as a departure or a kind of sleep. They may recognize the fact of physical death, but they don't separate it from living abilities. Death is seen as temporary and gradual. life and death can change places with one another, there really isn't an understanding of the universality and the inevitability of death. Their reactions to death: if they become seriously ill, they conceive of the illness as a punishment for their thoughts or actions. They may feel guilty and responsible for the death of a sibling. The greatest fear concerning death is separation from parents. They may engage in activities that seem strange or abnormal to adults. Because of their fewer defense mechanisms to deal with loss, young children may react less to a significant loss with more outward grief than to the loss of a very significant person. The loss is so deep, painful, and threatening that the child may deny it for the present in order to survive its overwhelming impact. Behavioral reactions such as giggling, joking, attracting attention, or regressing to earlier developmental phases indicate a child's need to distance themselves from the tremendous loss. Again, what can we do? Help parents deal with their feelings, allowing them more emotional reserve to meet the needs of their children. Help parents to understand behavioral reactions of their children. Encourage parents to remain near the child as much as possible to minimize the child's great fear of separation from the parents. If a parent has died, encourage having a consistent caregiver for the child, and again, promote primary nursing. The school-age child. Here, their concepts of death, they still associate misdeeds or bad thoughts with causing death and feel intense guilt and responsibility for the event. But because of their higher cognitive abilities, they respond well to logical explanations and comprehend the figurative meaning of the words. They have a deeper understanding of death in a concrete sense. Particularly fear the mutilation and punishment they associate with death. They may actually personify death as the devil, a monster, or the boogeyman. They may have a naturalistic physiologic explanations of death. By 9 or 10, though, children have an adult concept of death, realizing that it's inevitable, universal, and irreversible. Reactions to death. Because of their increased ability to comprehend, they may have more fears. For example, the reason for the illness, communicability of the illness to themselves or others, consequences of the disease, the process of dying, and the death itself can all be major concerns. Their fear of the unknown is actually greater than the fear of the known. So often parents will ask, should we tell our child that they're dying? Remember, the fear of the unknown is greater than the fear of the known. So the answer is yes. The realization of impending death is a tremendous threat to their sense of security and ego strength. They are likely to exhibit fear through verbal uncooperativeness rather than actual physical aggression. They are very interested in post-death services and may ask lots of questions as to what will happen to the body. Interventions help parents deal with their feelings, allowing them more emotional reserve to meet the needs of their children. Encourage parents to remain near their child as much as possible, yet again, being sensitive to the parents' needs. Because of the children's fear of the unknown, anticipatory preparation is very important. Since the developmental task of this age group in industry, interventions of helping the child maintain control over their bodies and increasing their understanding allows them to achieve independent self-worth and self-esteem and avoids a sense of inferiority. Encourage children to talk about their feelings and provide aggressive outlets. Encourage parents to honestly answer questions about dying rather than avoiding or fabricating euphemisms. Encourage parents to share their moments of sorrow with their children and provide preparation for post-death services. Adolescents, their concepts of death, they actually do have a mature understanding of death. They still very much are influenced by remnants of that magical thinking and are subject to guilt and shame. They're likely to see deviations from accepted behavior as reasons for their illness. Reactions to death. Here they're straddling childhood and adulthood, they have the most difficulty in coping with death. They are least likely to accept the cessation of life, especially if it's their own. Their concern is for the present much more than the past or the future. They're concerned with what's happening right now. They may consider themselves alienated from their peers and be unable to communicate with their parents for emotional support, and then they may feel alone in their struggle. An adolescent's orientation to the present makes it so that they worry about physical changes even more than the negative prognosis. So they may be more worried about that they're bald than the possibility of them dying. Because of their idealistic view of the world, they may criticize funeral rites as barbaric, money-making, and unnecessary. What can we do here? Again, help parents deal with their feelings, allowing them more emotional reserve to meet the needs of their children. Avoid alliances with either the parent or the child. You're there for the whole family. Structure hospital admission to allow for maximum self-control and independence. Answer adolescents' questions honestly, treating them as mature individuals and respecting their needs for privacy, solitude, and personal expression of emotions. Help parents understand their child's reactions to death and dying, especially that concern for the present crisis, such as a loss of hair, may be much greater than for the future ones, as I mentioned earlier, the possible demise. General information. As a nurse, you should facilitate interactions between the parents and the child, provide an atmosphere for open communication, find out what the child knows, thinks, and is currently feeling, correct any misconceptions. They may not understand what is wrong with them. Ask them, what is your biggest concern? Be honest with children. If they are dying, tell them that there is not a cure possible, but you still want to give them hope. We will take good care of you, and you will be free of pain, or it will be as controlled as much as possible, and we are here to provide emotional comfort as much as you need. Let the child know that they are important and their memory will live on in everyone's minds and their hearts. Hearing is often thought to be the last sentence to stop functioning before death, so we encourage the family to talk to the patient, even though they may not be responding. Common behaviors include hiding tears. They may try to take care of their parents. They might be doing bad in school, act out, or they may also complain of somatic complaints. Siblings are also often the most neglected after a child's death. Age and cognitive development significantly affect a child's reaction to death. During a chronic illness, siblings may be jealous because the sick child is getting so much attention. Again, your textbook does have a table for guidelines for supporting grieving families. We're going to cover that next. In general, stay with the family. Sit quietly if they prefer not to talk. You might even have a little tear here and there, crying with them if you want. But remember, it is about the family. So if you are just so close to the family and are unable to keep some control over yourself, you may want to have a different nurse taking care of this family until you are able to be less extremely overtly emotional. Accept the family's grief reactions. Avoid judgmental statements. Avoid offer rationalizations for the child's death. Avoid artificial consolation. Deal openly with feelings such as guilt, anger, and the loss of self-esteem. Focus on feeling words by using a feeling word in the statement. Refer the family to an appropriate self-help group for professionals if they need it. At the time of death, reassure the family that everything possible is being done for the child. And if they want life-saving interventions, because maybe this is a patient, somebody that's in the emergency room and it's not an expected death, please let them know that they are doing everything. And you may even want them in the emergency room so they can see that everything was done. Do everything possible to ensure the child's comfort, especially pain relief. Provide the child and family with the opportunity to review special experiences or memories in their lives. Express personal feelings of loss and or frustrations like, we will miss him so much. We feel so sorry that we couldn't save him or her. Provide information that the family requests and be honest. Respect the emotional needs of the family members, such as the siblings who may need brief respites from the dying child. Make every effort to arrange for family members, especially parents, to be with the child at the moment of death if they want to be present. Allow the family to stay with the deceased child as long as they wish to rock, to hold, and to bathe them if they would like. Provide practical help when possible, such as collecting the child's belongings. And arrange for spiritual support based on the family's religious beliefs. You may even want to pray with the family if they would like. Post-death, sometimes, especially if the nurse had a special closeness to the family, they may attend the funeral. This is okay. Initiate and maintain contact, maybe sending a card. Sometimes they may even invite them to come back to the unit. Refer to the deceased child by name. Discuss shared memories with the family. Discourage the use of drugs or alcohol as a method of escaping grief. Encourage all family members to communicate their feelings rather than to remain silent to avoid upsetting another member. Emphasize that grieving is a painful process and that often takes years to resolve. It is not uncommon to hear the voice of the person who has passed away, to have trouble eating, sleeping. They may feel very depressed and they may feel empty. Next, we're going to talk about the effects of illness and hospitalization on children and families. So the infant's response, typically about 6 months of age, this is where the infant is aware that they're being separated from their parents. They may be very anxious with strangers if the parents are not there. Separation anxiety can occur when parents are not present. So what can we do as a nurse? Have the parents stay with the infant and have them do as much of the ADLs as possible. Most hospitals follow a family-centered care approach, and typically one parent is allowed to stay overnight in the room with the patient. In addition, having a consistent nurse for the infant can definitely be of assistance. There are 3 stages of separation anxiety. The first stage or phase is a phase of protest. Here, the behaviors that one would observe during later infancy is that they will cry, scream, search for their parents with their eyes. They'll cling to the parents so they won't leave. They may avoid and reject contact with strangers. Additional behaviors that you may see during toddlerhood will be things like a verbal attack, telling them to go away. Physical attacks of strangers. They might kick, bite, hit, and punch them. They may try to escape to find their parents. They physically will hold on to their parents to force them to stay. Behaviors may last from hours to days. Protests such as crying can be continuous, stopping only when the child becomes so physically exhausted. An approach of a stranger may even precipitate an increase in their protest. Phase 2. This phase is of despair. Here you will see the child may become inactive, withdraw from others, depressed, sad. They're uninterested in the environment, uncommunicative. They may regress to earlier behaviors like thumb sucking, bedwetting, wanting to use a pacifier or drink fluids out of a bottle. These behaviors can last for a variable length of time. The child's physical condition can even deteriorate because they don't want to eat, drink, or move around. Phase 3 is called the phase of detachment or denial. Here, the child shows an interest in their surroundings and they're beginning to interact with strangers or familiar caregivers. The thing is they're forming new but superficial relationships. They look happy. Detachment usually occurs after a prolonged separation from their parent. Rarely do we see this in a hospitalized children because they're typically not in the hospital long enough. But for a child who is chronically in the hospital, they can experience this. Behaviors represent a superficial adjustment to the loss, and they can actually experience developmental delays in that phase of detachment. The toddler preschooler. So here they can actually see two unrelated events as cause and effect, like the dog's tail hit me in the stomach, so I got appendicitis. They may blame magic or people for illnesses. They can fear body mutilation. Separation is also a stressor. What can we do as a nurse? Having the parent audio tape a message for them and then leave the message there so the nurse can play it is wonderful. That way the child can at least hear maybe a story that on a recording device that the parent left for the nurse to play. You can leave the parent's clothing with the cologne on them, and then the child can hold on to that, and that can bring them some comfort. Ideally, we have parents present for rituals like a bedtime story or a special song. Tell the child right before you're going to be doing procedures. You don't want to tell them a long time before because then they're going to be upset. Do the procedure in the treatment room. We want to keep their bed as a safe space. Give them a choice if a choice is available. Let them scream and comfort them afterwards. Give them a treat if possible, like a sticker. So individual risk factors that can increase vulnerability to stressors in the hospital. So children that have a difficult temperament, they lack the fit between the child and a parent, children between 6 months and 5 years, male gender, below average intelligence, and multiple and continuing stressors. So if the child is frequently hospitalized, all of these things can increase the vulnerability to the hospital stressors. You also want to reinforce some of the benefits of hospitalization. They get better from their illness. They can increase in coping. They learn to manage stress and feelings of being competent in coping. And they may even have new socialization experiences. So parental responses to stressors of hospitalization. Know that it's not uncommon for parents to question the skills of the staff. So it's really important to give families the information that they need in simple language. Make sure they understand what's going on. Tell the families that they can seek assurance from caregivers. Some of the emotions that they can feel is disbelief, anger, guilt. This especially occurs if the illness is a sudden onset. They may be fearful and anxious, and this can be related to the child being in pain and how serious the illness is. They may be frustrated, especially if they feel like they need more information and they're not getting it. And then they can be depressed because they feel powerless and they aren't able to control what's happening in terms of the child's illness. We do want to normalize the hospital environment, although we know there's nothing normal about a child being in a hospital. Things that we can do is maintain the child's routine, if possible, time structuring, self-care in an age-appropriate manner, schoolwork, friends, and visitors. Here you will see Eric's daily schedule. We talk about his breakfast and morning bath, when the medications and dressing changes will occur, physical therapy, lunch. We even have school time scheduled in, more physical therapy, dinner, meds, dressing change, and bedtime. Here you can see that time structuring can be an effective strategy for normalizing the hospital environment and increasing the child's sense of control. Unfortunately, they tend to sleep less in the hospital because as nurses, we're often frequently interrupting the child's sleep as we provide care. Nursing care of the family, we want to accept cultural, socioeconomic, as well as ethnic values. Discharge planning starts at admission. When parents understand and are well informed, they are more likely to remain with the child. Clear understanding of should be an understanding of what they can expect from you, as well as what you expect of the family, is very important. So how can we prepare for hospitalization? Although the family will be anxious, if the hospitalization is planned, you can have them take a tour of the hospital. You may do a puppet show in advance based on the child's age. Let the child see and play with the equipment that may be used. So if you're going to be using a stethoscope or a blood pressure cuff, let them play with it so they can be less fearful. Parents can prepare the child by reading stories and using coloring books that help to reinforce information. If it's an unexpected admission, you want to orient the family to the environment, the routine, establish expectations, allow for questions, and explain things like the call light use, the remote control use, TV, bed, bathroom, restroom, and how the child life specialist can support the child's needs and help them to understand what's happening to them while they're in the hospital. Teens may want to talk to other teens who have had similar experiences for support. Siblings' reactions. Siblings may feel jealous due to a decrease in personal attention. They may be anxious and fearful that the siblings will die. So please remember, give them information, tell them what is happening. They also may feel guilty or frightened, or maybe they were mean to their sibling and they feel like they caused the illness. Sibling visitation is very beneficial to the parents, the siblings, and the patients. Prepare for the visit with developmentally appropriate information. A little bit about play therapy. There are a few different techniques that you may see. So play therapy helps with the development and can be used to teach a child about health care and allow the experience of fear and anxiety to decrease because of this play therapy. Also, play therapy can give them a sense of control over scary events. It can teach them relaxation. It can teach them diversion, decrease homesickness, and increase interaction with others. The benefits of stories, you can have children tell a story about what's happening to them. Caregivers can then make up a story explaining the illness and the hospitalization, including emotions that the character in the story may experience. Dramatic play. Here you provide dolls and equipment for play sessions. Make sure that they are safe. So there's nothing wrong with allowing them to play with a syringe. Just make sure there's no needle on it. Toddlers. Here, again, remember we talked about that separation anxiety and stranger anxiety in the hospital. So approach them slowly. You want to decrease the stranger anxiety. It's best if the parents are there. So talk to the parents first, and then slowly you may start talking to the child. Play peekaboo with them. Read them stories. A doll can be used to express feelings by recreating a stressful event. Let them play with safe hospital equipment with supervision. As I mentioned, needleless syringes, a stethoscope and bandages, and you can also let them play with home toys like pool toys or blocks. Preschoolers. Dolls can be used to have the child talk about fantasies, fears of mutilation, and harm. Let them play, again, with safe hospital equipment. Crayons, coloring books, recorded stories, Play-Doh, and magnetic boards are all wonderful toys for the preschool child. The school-age person. Here, play therapy is a little bit less important. They may regress. Dolls can be used to discuss the cause of treatments or the cause of the illness, and they can be used to teach them about the treatments of the illness. This is typically used for the younger school-age child. Know that your older school-age child might want to keep items that have been used on them so they can tell their friends later. Remember, school-age children like to collect things. Play should promote self-mastery, things like games, books, crafts, playing computer games. They like to collect things, as I mentioned. So maybe for every time they had a successful event in the hospital with a procedure, they can get a sticker. Adolescents, here they need recreation more than plate treatment. Allow them to call their friends. Let their friends visit. Maybe have a video night or a pizza night on the unit. Allow them to visit other teens on the unit if it's possible. Give them options in care and recreation to allow for independence. Next, we're going to talk a little bit about pediatric variations of nursing interventions. Here, we're going to address initially the legal and ethical issues, talking about informed consent. Remember, the doctor must legally obtain informed consent, but the RN may witness and respond to questions. So the doctor must give an order to get informed consent. These items, they need to describe the treatments, the benefits and risks. They need to inform alternative treatments. They need to inform of the effects of no treatment. And then the components of an informed consent are, they must be a legal, competent adult. There are some exceptions to this, which we're going to discuss momentarily. Next, they need to receive the necessary information to make the decision, which we just addressed. And the decision must be voluntarily made without force or coercion. So, children under the age of 18 may give informed consent under very specific circumstances when they are the minor parent of a child patient. So if a 15-year-old has a baby, they are able to consent for that baby. If they are an emancipated minor, so they're under the age of 18, they're not under the parent's control. Examples of this include military service, married, are they living independently, or was it legally granted? The mature minor, this is 14 to 18 years of age, but know that this can vary state by state. In the state of California, it is actually 12 years of age, and these people can seek reproductive care, care for mental health, and substance abuse treatment without their parental consent. Regarding research participation, children 7 years and older should be given information and questions answered, and they can actually give something called assent. Assent is a voluntary agreement to participate or take treatment. It's not a legal requirement, but this can be considered an ethical one. Child's rights versus parents' rights. In general, we say parents rule unless. The parent's choice does not allow for life-saving treatment for a child. Sometimes Jehovah's Witness may say no to a blood transfusion, and without this transfusion, you can actually get a court order, and then the child will be allowed to get that transfusion. Next, a conflict of interest. If a child has been abused, we can do skeletal x-rays and do a skeletal survey, which is a full body x-ray, and you don't need consent then either. If the parents are incapacitated, like there's a car accident, of course, in an emergency, you can provide care without consent. Parents have what we call the durable power of attorney. They describe what should be done. They can sign DNRs and give directives onto how to handle the remains of a child and whether or not to donate organs for transplantation. The people that they contact, that the hospital will contact, that is the One Legacy organization. They are in charge of organ donation procurement. Remember, children don't sign advance directives. They are not legal adults. Do not interview or examine teens with parents in the room. Remember, they do have a right to confidentiality. Know that it's not 100% confidentiality. You need to let the teen know that the exception to confidentiality includes things like confessions of wanting to kill themselves or kill somebody else, or if they are involved in any kind of abuse or anything else that would be considered like illegal if they were shot or if they were raped or if they were involved in a stabbing. Those kinds of things, because those are crimes, those cannot be kept confidential. The benefit of speaking with teens privately without the parents in the room, this can actually help obtain a more thorough and accurate assessment. So teens 12 and over, we can do the HEADS assessment as well as the regular history and physical. This is part of it. And we assess the home, education, activities, diet, drugs, depression. And in terms of the diet, drugs, and depression, there we're also looking for vaping or smoking. S is the safety, sex, so are they sexually active, and are they having thoughts of suicide? In general, when we're looking at some guidelines for preparing children for procedures, you want to determine the details of the exact procedure to be performed. Review the parents and the child's present level of understanding. Plan the actual teaching based on the child's developmental age and existing level of knowledge. Incorporate parents in the teaching if they desire, especially if they plan to participate in the care. Inform the parents of their role during the procedure, such as standing near the child's head or in the child's line of vision and talking softly to the child. While preparing the child into the family, allow ample discussion to prevent information overload and ensure adequate feedback. Use concrete, not abstract terms, and visual aids to describe the procedure. For example, use a simple line drawing of a boy or girl and mark the body part that will be involved in the procedure. Use non-threatening but realistic models. Emphasize that no other body part will be involved. If the body part is associated with a specific function, stress the change or non-involvement of that ability. So an example of this would be, just because a child has a tonsillectomy, they still can speak. Sometimes children will think they've had a tonsillectomy and now they no longer can speak. So you want to dispel that notion. Use words appropriate to the child's level of understanding. A rule of thumb for the number of words is the age in years plus 1. Avoid words and phrases with dual meaning unless the child understands such words. Clarify all unfamiliar words. Emphasize sensory aspects of a procedure. What is a child going to feel, see, smell, and hear? And what can the child do during the procedure? Remember, always tell the child what you want them to do. Allow the child to practice those procedures that will require cooperation. Things like turning, deep breathing, using an incentive spirometer. Introduce anxiety-laden information last, like starting an IV. Be honest with the child about unpleasant aspects of a procedure, but avoid creating undue concern. When discussing that a procedure may be uncomfortable, let them know that it feels differently to everybody, and then afterwards you can even have the child describe how it felt to them. Emphasize the end of procedure and any pleasurable events after the procedure. Stress positive benefits of the procedure. Once your tonsils are fixed, you won't have as many sore throats. This concludes the lecture addressing the behavioral objectives for week 2. Note that this is part A. We will continue with part B. Please, in a different video. Please be sure to read your textbook and complete the assignments for this week to facilitate the utilization of this content and apply it to nursing practice. Thank you and have a good day. Don't forget to watch part B for the week 2 content.